And I also practice in infectious disease in Denver. I'm a physician. And I'm going to tell you about our antibiotic that we're working on at Crestone called CRS-3123, which I'll refer to as 3123, for primary and first recurrence of CDI. So just a little bit about Crestone. We're a small company in Boulder, Colorado, that was founded in 2009. And the company pretty much entirely works on new antibacterial agents that have novel mechanisms with a mission to address antibiotic resistance and infection control. And then almost all of our programs that are advanced are funded by the NIH currently. So these are some of our programs that are at our company. The first one is our CRS-3123 for C. diff, which is the furthest along in development. We are in the midst of, we're about 1 year in to a phase 2 trial. For this, we also have a gram-positive drug that targets MRSA and VRE, but that is in preclinical stages, almost to phase 1. And then also a drug for non-tuberculous mycobacterium and tuberculosis. And then for 3123, we're looking at also some exploratory studies on microbiome modulation with that drug. And some secondary indications that aren't C. diff for it. And then also we have some gram-negative agents and antivirals. So as you all are well aware, C. diff is caused by a spore-forming toxin-producing strain of C. diff. It's the leading cause of hospital-associated diarrhea. In the hospital, there are over 200,000 cases annually. Of course, this number is higher when you include all the outpatient cases, but and 13,000 deaths annually in the hospital. And those patients that get C. diff have a disruption usually in their healthy gut microbiota, but not always. And this is most commonly with antibiotics, but other things can cause that disruption. And then also it's increasingly seen in the community. So by and large, to treat this illness, we still use antibiotics as first-line therapy. There's probiotics, vaccines, and antibodies in development right now for supplemental use, but they're primarily used for recurrence or to prevent recurrence, so as an addition to the antibiotic therapy. And then as a last resort, for multiple recurrent cases, we have FMT in the guidelines. So this treatment is dominated at the moment by suboptimal medications, so vancomycin and metronidazole, even though metronidazole is not in the guidelines except for a few various cases. But there is a need for a narrow-spectrum antibiotic to treat this illness so that we can reduce the recurrence rate. In terms of what we have used that has not worked is metronidazole and vancomycin. Both drugs are associated with a high recurrence rate, so 20 to 40%. Also, both of them negatively impact the gut, and I have a couple slides that show this in more granular detail. Metronidazole isn't in the guidelines, likely for this reason, except for a couple exceptions. Fulminant C. diff is one of them, and then it's also in there for children. Fidaxomicin, approved in 2011, is narrower spectrum than vancomycin, but it could be narrower, and there's room for improvement with this antibiotic. It is in the guidelines for first episode and for first recurrence and beyond, but it still negatively impacts the gut microbiome to some extent. And then the pipeline for new antibiotics for C. diff is even narrower now. Over the last 3 years, there's been a couple programs that have failed, likely because one of them is cadazolid, but it is likely because these antibiotics are still just slightly too narrow, so they don't prove to be any better than vancomycin. But I'm hopeful for some new programs that are, occurring right now in 2022. So using suboptimal treatments for C. diff, vancomycin, metronidazole actually can drive recurrence, sadly enough. But once you have one recurrence, your likelihood of getting a second recurrence, and then from a second recurrence to a third recurrence, it just accelerates. So you're 30% likely to get a second recurrence if you have a first recurrence, and so forth. And then as you go down the recurrence pathway, the morbidity, mortality, and cost dramatically increases. So not an ideal situation, absolutely. So this group tends to know this, but spores are omnipresent, especially in hospitals, nursing homes, and now, definitely in the environment as well. And then when we disturb gut microbiome, even with chemotherapy, immunosuppressives, that can affect gut microbiome and broad-spectrum antibiotics. It is just a setup. We are very precarious at the moment to have this disease flare, so we need something narrow to protect us. The photo on the right is growth of C. diff colonies after from a sterile glove after a healthcare worker was in contact with a C. diff affected patient at 1 hour after they showered. So a little bit about 3123. It has a novel structure, and it has excellent potency against C. diff. It stops the growth of all different C. diff strains tested, so that means we haven't found an isolate of C. diff that is resistant to it to date. And it does spare most of the beneficial gut microbiome. So the way that it works is and I have another slide about this, it's a protein synthesis inhibitor, and it inhibits the toxin production of C. diff, but also the C. diff from forming spores, which could potentially lead to reduced recurrence and reduced transmission of the disease. And as I mentioned, probably due to his novel mode of action, there isn't any C. diff strains that are resistant to it as of yet. So a little bit of a biology lesson here. Where CRS-3123 acts is when RNA is translated into proteins, and toxins and proteins are what toxins and spores are what sort of drive this illness. The toxins are what give you diarrhea. The spores are what makes this disease persist and recur. And so this is a MET-RS inhibitor, so methionine tRNA synthase inhibitor. And that's the subclass of protein synthesis inhibitor. So even in the stationary phase of C. diff, there are large amounts of toxin produced when patients on fidaxomicin or vancomycin or metronidazole. Those things can keep making a patient feel ill, keep having them have diarrhea while those antibiotics are trying to kill the organism, because the toxin B RNA is very stable, and so it hangs around. So these on the left-hand side is a lot of the species of gut microbiome that are in a healthy gut. There are many more, but these are the ones that have been studied the most. And as you can see, when exposed to the various medications that we use for C. diff, they are killed. So the lower the number, so what MIC is, the lower the number, what that means is the least amount of that antibiotic is needed to kill the bacteria. So a very minimal amount of that antibiotic is needed to kill that species. So CRS-3123, all the way on the right side, what we found in phase 1 studies, so these are stool samples of healthy volunteers, is that it had minimal to no effect on some of these phylogeny, which was encouraging to continue investigating it as a treatment. So in our animal model, we found that if treated with 3123 and Vanco for 5 days in a hamster model that had C. diff, that there was a survival benefit. Patients with CRS-3123 did better with those that were untreated, certainly, which all passed, and then those that had vancomycin. These are our 2 phase 1 studies. So again, these are healthy volunteers that took the drug as a single dose and then a separate study as an ascending dose for us to find out which dose was going to be the one we'd choose. And what we found when patients were treated with 10 days of the antibiotic, there were no serious adverse events, and there were only mild adverse events seen. And then we found from this study that there was a low impact on the gut bacteria, but also that there's a high concentration of the antibiotic in the gut, which is what you want to treat C. diff, because that's where the bacteria is acting. And all of these things warranted the progression to phase 2 for this drug. And some pictures of also the healthy gut bacteria groups that are found in our guts, but when they were treated with CRS-3123, it did have minimal to modest changes. We had the highest dosage that we tested had moderate changes, but even at the highest dose, there was actually no groups of bacteria that were lost, which is important. And we've decided to test the middle two, or the first two, 200 and 400 twice a day in phase 2, given this information as well, so that we could spare gut microbiome. So I'll tell you how we're doing the phase 2 trial. It's a randomized double-blind evaluation of 3123 and oral vancomycin in adults only with Clostridioides difficile infection. So we're looking at adults only right now with primary or first recurrence of CDI. The patients have to have a stool positive for both GDH and toxin. Those are 2 proteins of C. diff, and we are using tech labs, Abbott, Alere, Quick Check Complete Test. We're actually using them directly for all of our kits for our sites. And then the key exclusion for this is a narrow population phase 2. We're really looking, at safety and efficacy, but we're not testing any subjects that have inflammatory bowel disease or if their first episode of C. diff did not respond to vancomycin, just because we have a vancomycin arm. If they currently have life-threatening C. diff, or if they are on immunosuppressive medications, or have an immunodeficiency underlying, or if they have severe liver disease. So these are the 3 arms. It is blinded. You would be blinded to one of 3 arms, either 200 or 400 milligrams twice a day of CRS-3123 or vancomycin 125 4 times a day daily. Everyone is treated for 10 days, and we have 30 sites in US and Canada. Not all of them are active yet, but almost. And then we hope to get 90 to 108 patients total. These are where our clinical sites are. This is something that I was thinking, Christian, we could put on the site somehow, or anyway integrate into if they had a potential patient someone was talking to wanted to be in a trial. But anyway, we can talk about that later. Mainly, we have sites on the East Coast, Midwest. We have 2 Canadian sites, Dr. Silverman and Dr. Louie right now. Yeah. Tom Louie. So this is just a quick schematic. So let's just say one of your advocates was called and wanted to have an idea, but it's a 10-day course. And then patients are followed for 60 days after they finish treatment to monitor for CDI recurrence. So a total of a 70-day commitment, but you are getting about 8 clinic visits with a physician and a coordinator. So you receive a lot of care. And the red arrows are telephone visits with the nurse coordinator. To make sure to see how they're doing. So what are we interested in? Obviously, does this work? So we're measuring the rate of cure after a 10-day course, but then at day 12, which is about 48 hours after they stop C. diff medication. That's common in a lot of C. diff trials. And then do they have recurrence? So we're following 60 days after they finish treatment. Does C. diff recur and how quickly, and et cetera. Is it safe? So while they're on the course of treatment, is there any adverse events that have happened when patients are on CRS-3123? And then lastly, how does a patient feel? So we are collecting health-related quality of life in patients that have C. diff and they're on our drug. So we're doing this with a daily diary. They fill out what their stools are, but also symptoms that they're having with C. diff. I'll tell you a little bit about that. We're using CDI-DaySyms. If you're interested, it's a patient-reported outcome that has been validated, and it is only 10 questions, and it has 3 different components. So we look at diarrheal symptoms, abdominal symptoms, and then other systemic symptoms. And then each of these they would grade on a 5-point Likert scale, and they do that for the 10 days they're on treatment. They don't necessarily do it when they're in the follow-up phase, but we can see how our patients are feeling when they're on this medication. So what I was hoping to relay to everyone is why should you participate in a clinical trial, ours or other, in C. diff, is that you get a really close follow-up with your treating physician, but also with the research staff. So I mentioned there was 8 visits in the beginning. You're going to probably see the doctor every 4 days. You're going to have the medication and the clinical care all free of cost. So there's no copays for medication. There's no copay for any of the clinic visits. And you are getting seen frequently. You also have someone on call 24/7 to talk to because you're under such close supervision because you're in a clinical trial. It is an opportunity also for a patient to get a new and potentially more effective treatment before it's widely available. These, as you know, like if a new drug is in development, it can be 2, 3, 4 years before it's approved by the FDA, and so there's a huge amount of time and effort that goes into getting a drug approved. So this could be their one opportunity to get something novel. It also can contribute to the advancement of these treatments for this illness. So with C. diff, for instance, if we don't have numbers of patients that get into these trials, we're not going to get new information to move the field forward and get new treatments for the illness. And then lastly, compensation for your time. For this study and then for all other research study, it's quite common that you're paid per visit. So if you come into a clinic visit, and even if you complete a phone call, there is a monetary amount that you receive for your time that we're allowed to do. So in terms of CRS 3123, so it could be the narrowest spectrum antibiotic available to treat C. diff. Since it really does target C. diff, it is like precision medicine. And it selectively inhibits C. diff and not our good, healthy gut microbiome. So it could lead to a faster recovery of gut health. And then also it inhibits toxin production. This could lead to patients feeling better quicker and decrease length of stay in the hospital. And then it inhibits spore formation, which we're hoping will lead to fewer episodes of the disease going forward. So do we need a C. diff drug? Yes and yes. But ours is, I think I'm hoping that it improved patient outcomes will give us, we need more treatment options for physicians. They have very few treatments currently. And it could provide a cost benefit of these treatments. So that, again, would be fewer hospital readmissions, fewer clinics visits, shorter length of stays in the hospital. So I want to thank Wendy Ribble. She's our project manager for Crestone. She helped me make these slides, but also our founders are Urs Oxner, Nebojsa Janic, and Thale Jarvis. And these are many other scientists that work for Crestone that have been working on this treatment for a couple years. And one thing I wanted to talk about, please contact us if you want more information about this trial. But then also, I wanted to see if I was really happy to be here to talk to patient advocates because I know they talk to patients directly that have C. diff. And I do the same because my name's on the website for this trial. And so one thing I do is if they're not a candidate for mine is trying to connect them to another trial. Because I'm a little biased because I'm a physician, but I think that could be the most ideal situation. If there's something that fits them, would be a novel treatment. Otherwise, they're going to probably go on something, unless they can get an FMT. They're probably going to go on something that might not be that effective, sadly. So anyway, if there's a way to connect all of us somehow, I think that would be a great idea. So
thank you so much, Katie, for that. I've been very curious to learn more about this since we got in touch with Crestone last year. Also kind of excited that you guys are collab.
Work with Tech Labs.
Love that. So we should definitely talk offline about, because yes, the answer is yes. And we're in a soft launch right now for our patient support network, peer support network.
Okay.
And as we grow that, we really want to have almost we have a map on our website now. We want to make sure it's up to date, where when somebody's talking to the peer supporter, they can say have you looked here where there are clinical trials, and we really want to be able to push people towards something. In addition to giving them sort of moral support, but we're not clinicians. Like all we can do is say like, you know, have you tried this? Have you tried that? Just to help people walk through it. Because as Marianne was saying earlier, like, you know, any of us that had diarrhea for 4 days, we would not be in our right minds, let alone like for 6 months, you know? So a question I had for you, maybe this isn't determined yet, but for the phase 2, are you guys trying to prove superiority or non-inferiority?
Non-inferiority. Yeah.
So non-inferiority plus less recurrence is really the cell. Okay.
Yeah. I think we would like to prove superiority in the pivotal trial, which will be phase 3, right. To be approved. Yes. That hasn't been designed yet. It'll depend on what we find here.
Just thinking about.
Yeah. Yeah, absolutely. I mean, we feel it would
be. I feel like lessening recurrences should be considered superior.
Yes.
Like I just think it should be, like, it works better.
Yes. Yeah.
But I'm not a microbiologist, so they don't care what I think about it. Yes. Do other folks have questions?
I have a question. So this might be a little too technical, but methionine tRNA RNA synthetase is important for life in general. So why do you think that this is specific to C. difficile rather than other bacteria?
You know, I had a slide here about that. It is MET-RS1, so it actually only targets gram-positive bacteria. So bacteria that have MET-RS2 are all of our gram-negatives, all of our anaerobes, and a couple streps. But it does hit, for instance, MRSA. So is in there general Staph aureus MSSA, and like strep viridans, you know, things like that. So, of course, there are other bacteria that are affected, but it's a MET-RS1 inhibitor, not 2. And so if it hit 2, it would kill the gram-negatives and anaerobes. So, yeah.